Hi, Ben. This is Deanne. I have a couple things. First off, I would like to make sure that everyone knows that Nishant Srinivasan is a father of a newborn baby boy
Mm.
who arrived just a couple of days ago. Actually, July 1st, I believe. So we're all very excited for Nishant as his family grows. And then I'm happy to announce that my son William yesterday was engaged to a young lady from Fort Wayne, Indiana, and we're very excited about that as well.
Devil, congratulations. Happy
It's nice.
news.
It's nice to have happy news, isn't it?
It is. Well, I will celebrate that. I think we're all enjoying having a summer that has some freedom that we didn't all enjoy last summer. And I know many of you are having just some family time and personal time that was much more difficult to appreciate and enjoy a year ago. Maybe before we start, I think we all want to acknowledge that Dr. Lynn's leadership during the pandemic, which was had played an enormous role in the success of UI Health in playing a really important role in the city and the region in responding to the pandemic. I know many of you were on the many early morning phone calls where she shepherded us through multiple stages, and we're all really grateful. And I think to having her work with us as we kind of move through a period of adaptation, change, and restructuring is super helpful. Jordan, how many folks are on now? Okay, well, let me go ahead and get started. Thank you. So I just wanted to just, again, as we kind of, look to the future and plan our next steps and adapt to a changing environment, I think it's really important to remember the mission and the vision and the values that we bring to Chicago and Illinois in child health in our education, research, and clinical missions. And I think it's worth rereading them. Our mission to ensure children and families have access to healing, service, and innovation throughout the lifespan, and to assure training and education opportunities for the next generation of pediatric healthcare leaders. Our vision is we are dedicated to a world in which all children, families, and communities achieve their full potential. And then our values are equity, authenticity, collaboration, diversity, innovation, and quality. And what we're going to be talking about today are some adaptations, changes, and maybe what could be called restructuring around maintaining, sustaining our mission, while maybe changing how we do some aspects of it or adapting. So I'm going to go to the next slide. So I think we've already gone through, we've got to 12:05 with our celebrations, introductions. We'll go to trends update. So we're just maybe, Jordan, just go back one slide just for a minute. The way I try to structure this is that we'll talk about some of these, I'll call, trends that are occurring at national, even international, local, and regional levels that are impacting us and how we manage our mission and vision and our values. And then some key issues that have developed internally for us that are really, at least substantively, a reflection of some of those, you might say, large scale trends. How we're planning to adapt and restructure to meet the needs of the external and internal environment. And then we'll try to have almost half the time for open discussion and question asking. So first I thought, well, you might have to read it. There've been a lot of achievements and things that have gotten done this year, despite or because of the pandemic, in a situation with a lot of external and internal demands. And I just want to say that we did complete the U.S. News World Survey. We got 7 of 10 specialties actually scored for the first time. That puts us in the top 100 of the approximately 450 children's programs in the United States, which I think is well deserved. And I think maps on other ranking systems that we have kind of made it into that top quartile. We successfully passed with really flying colors 4 separate IDPH inspections, with hospital and other departmental collaborators. We've had many other successes in terms of quality improvement, outcomes across many units, despite many challenges. And we've been able to gradually reopen our inpatient program iteratively through a series of gradual expansions that actually occurred over moving, I think, 3 to 4 times, depending on counted. We also had some real important success at the outpatient space. We made over 12,000 calls to families. We got through probably a substantial portion of our primary care population to check in with them and offer them help. And our CHECK program, our federally funded population health project, is really now finally on independent funding after several years of successful transition. I'll say that the research mission is also going extremely well. I believe this year we will actually have another year where there's a year-over-year increase in research funding. And despite some of the challenges that we've encountered educationally, I think we've had a pretty favorable response from at least some of the learners about all the work we've done to kind of optimize the environment that we do have. Next slide. So what's the big picture? And I know some of this is almost cliche, but I think it's worth pausing and really understanding. The rate of organizational change has accelerated across the 20th century. And this actually increased even further in the 21st century. Organizational survival, even a century as our department has, requires constant assessment of mission and circumstances. If you look at the history of our department, it's actually been on a variety of different clinical platforms over the years. It's been at Cook County, it's been at Michael Reese. It's always been an innovator wherever it's been. As you all know, as I mentioned before, the first, pre-NICU was started 100 years ago by the first chairman of this department. At that time, I believe at Cook County Hospital, and then later at Michael Reese. The second thing I wanted to say on a policy level, more contextual to this historical moment, is there are enormous cost pressures on Medicaid. What you don't realize is that the state budget really comes down to essentially education, roads, and healthcare, and healthcare is Medicaid. Medicaid costs have increased spectacularly for states over the last 30 years, and they're crowding out roads and crowding out education. It's one of the reasons that college tuitions have gone up so dramatically. Though the child health budget is only part of the Medicaid budget, it's a substantial part of it. Almost certainly over the next 10 to 15 years is going to be increasing focus on Medicaid, obtaining value in a value outcome, that is cost and clinical and social outcomes for children. And I think we're actually very admirably positioned to respond to that expectation from the state. And then I would say adaptation is a constant process for health organizations to survive and thrive, for all organizations, but particularly healthcare organizations, because the healthcare business is probably one of the most complicated businesses that actually exists. Next slide. So what are some major trends going on? And many of us realize this, but we don't really realize the impact of it. Child hospitalizations have been falling at 4 or 5% a year since 1990, probably even before that. So any healthcare institution that was built in the 1970s was built for a child hospitalization rate that was probably 2.5 to 3 times what the current one is. By estimates by consulting firms, there are currently 450 excess medical surgical children's beds in Chicago. Not PICU, but medical surgical beds. During COVID, there was a 25 to 40% decline in emergency room visits and hospitalizations. This challenged children's hospitals across the country. It particularly challenged freestanding children's hospitals that were not linked to a university or a larger health system. At one point during the pandemic, collectively, children's hospitals were losing $1 billion a month. There's increasing consolidation and competitiveness in Chicago for clinical services for children. We've seen the closure of multiple child health programs in Chicago and Illinois. This is occurring in multiple states and actually causing major problems in smaller regional hospitals and rural areas. The health systems have been impacted by the pandemic in multiple ways, and they are still recovering. And then I said for payers, there's an increased interest in cost and value-based care. And there's an increasing trend towards, pushing for more ambulatory services and away from inpatient. and also for care in between hospitalizations or in between ambulatory visits. Really like a kind of a constant continuum of care. Next slide. What's happening in pediatric, our subfield, and this is a combination of global to regional. There's an increasing interest in health equity for rural and marginalized children. And marginalized can be described in a variety of ways. We are certainly within the framework of one, major sources of marginalization, in urbanicity, ethnicity, income status. Improving outcomes and reducing costs for children with specialized healthcare needs is a major focus federally and in terms of state governments. And again, we're very well positioned for both 1 and 2 to help, to serve. 3, answering more complex research questions with integrated methods. People want more research done for less cost and more things answered. Our T1 through T4 research program is really well suited to this. And I think it's one of the reasons we've been very successful in research funding as a group. Early intervention for building a resilient, inclusive culture in pediatric practice. I think this is something that we also have thought a lot about and are continuing to grow into. Use of technology to improve care and costs. Certainly the Epic transition was a major improvement overall and is offering new possibilities to obtain, track data. And I think we're just beginning to tap into the quality improvement potential. But the movement to Epic was a major shift for us. Tremendous work was done by our faculty to really design effective templates and make it work as well as it has. And then there's really increasing integration of child health into life course models. This is happening for a variety of reasons. Lifespans are expanding. Health systems have to look at resource allocations across age groups, and in fact are constantly cross-subsidizing different programs within the health system. Adult programs may subsidize child programs may in some cases subsidize adult programs. Health systems are budgeting across specialties and across age ranges. And so in some of the discussions that we've had in the last few weeks or that we're going to talk about now, I wanted to make it clear that within the health system we are in, there is a constant focus on how to make the best possible outcome for all age groups, but specifically also for children as a specifically potentially disadvantaged group that needs significant resource investment to deliver the care model. Next slide. So, what are some of the key issues internally? And some of these have come up, I think as far as, an immediate concern in the last week. And one of the reasons I wanted to wait is I wanted to be able to talk about some of these things in a more comprehensive way. So first of all, patient volume, we're still recovering towards a pre-COVID baseline. We'll go through some of that data. I think that ward and PICU lag most for a lot of complicated reasons, which we'll get into. Some of them structural, some of them policy, some of the reputation change, and some of them still recovery from the pandemic itself. The transfer to 5 Southwest to an adult status unit, and then the plan for incremental addition of beds in 5 West to meet at least the immediate needs, and then planning beyond that for how do we manage a volume of patients that may extend beyond the footprint in 5 West. The budget, the deficit actually will decline again in fiscal year 21 through tremendous work by Christine and her team, and all the faculty that have made many adjustments and sacrifices this year, as well as the administrative staff who've worked really in a reduced staffing environment. However, there are really multiple cost pressures in fiscal year 22. Revenue is likely to be flat in fiscal year 22. So it poses a real burden on the cost structure, which we'll talk about a little bit later. There's increased interest in UHealth Pediatrics in partnering with us by other institutions. The partnership with Shriners, it continues to develop, particularly around the outpatient setting, but also the potential for expansion of inpatient relationships, specifically in consultation services. The external validation of the program strength by U.S. News, IDPH site visits, research funding and rankings has made us an increasingly attractive partner for multiple institutions. And finally, the anticipated expansion of ambulatory settings. The state legislature has allocated $22 million in consort with the health system. That is a combined allocation that included some funding from our hospitals, about 20% of it, 25% coming from the hospital, and the rest coming from the state legislature. This is a tremendous vote of confidence for in the child health enterprise by the university leadership as well as the state legislature. And then active discussions and planning are going on around the possibility of a clinic at Shriners and at other sites. These would be newly renovated or expanded clinics that might evolve. So it's going to be planning and evolution also within the outpatient health system. Next slide. So I thought just to go into details a little bit of some of the trend lines, just so we're kind of looking at common data. This is the U.S. News and World Report of Illinois hospital. Most of the Illinois hospitals, I think we may not be missing actually the OSF hospital in Peoria. But basically, if you rank Illinois hospitals by total number of specialties scored or ranked, we're actually number 3. If you look at the U.S. News sets it up on their page, we're number 5 in Illinois behind Comer, Lurie, the OSF hospital in Peoria, and Advocate, but that's it. And it took years of work to get to this point, both of the incredible programmatic development work of our faculty, but also the documenting it in a 450-page submission. They used 3 years worth of data, so it's very important for the consistency. I want to just congratulate Dr. Schreier and the 7 section chiefs involved, which I had named in the prior communications, and the institution is very, very grateful for this work. Next slide. This just shows the different specialties. I will send out to all the faculty a wonderful detailed report that shows both the above average, the excellent, the average, and below average. And what you'll see when you look at our specialties is almost the vast majority are excellent or above average. There's some average, and there's very little below average on all these specialties. Given the fact that a lot of this is volume-based, which means we have to score primarily on programmatic features, this is a tremendous accomplishment by this faculty. Next slide. Okay, so here's this is the outpatient trends, and if you can look at the graph, which goes back, I think, to 2015, what you can see, there's a regression line in the middle. The reason it's going down is because of the deep drop that we had during COVID, which you can see in that huge V-shaped line towards the right side of the graph. What you do see is that we've had steady recovery and a recovery that's continuing even this month, to the point that June was actually above the same the month of June 2019. So we're seeing some really nice recovery, even with the limited staffing within the CYC itself. So if you dropped actually the COVID period, this line would probably be flat, basically. Okay, next slide. Okay, this is actually a trend lines of inpatient census, and if you look to the far right against the same period, what you can see is a dramatic drop during calendar year 20. And then a recovery. And you can see there's actually kind of a nice recovery going on in all the units. As Deanne's talked about, there was a drop off in births worldwide that's now recovering. What you can't see, it's kind of interesting. If you look at the lines below, which include newborn, PICU, and ward, although we've had a significant drop on the number of admissions, and we'll talk about that in subsequent slides, by some aggregate measures, it's been surprisingly static. Part of this depends on how you count the numbers, and this is probably, primarily the hospital numbers. Our numbers are more accurate, more complete, and they do show a more substantive decline. But you can see there's recovery going on. Next slide. This looks at actually the last 12 months or last 9 months since we've had EPIC, and the red lines are deferred admissions. The blue line's actually the census. And what you can see is, of course, you've been able to care for the vast majority of individuals. We are probably losing one person per day for transfers out, and one census count per day for transfers or redistribution internally, maybe 1 to 1.5. It is significant, but I want to put it in proportion to the number of kids that have actually been cared for. And that's because the faculty that have operated out of that unit have been incredibly careful to manage and utilize this bed. You can see some days the actual number of people in and out has actually been 14 on essentially an 8-room unit, basically, which had a 10-bed nursing staffing. Next slide. This shows a little more dramatically the hospitalizations. This is actually the number of individuals in and out of that unit every month, which usually is a dramatic drop during COVID. It's gradual recovery, and as Andrew's noted, we're getting to the point where we're going to break out of the control line and get back further movement. The hospital recognizes that we are going to have increasing census, that we are having, probably the first beginning of the viral season, and they're going to work with us on the staffing and the beds, which we'll talk about further. Next slide. This looks at, this is outside transfers. You can see that the transfer rate, it was highest when we had Mercy on the far left side, then it had sort of a steady state, and now we're kind of around 10, where we had been at 15 to 18 before. Again, as we reestablish a more adequate bed capacity on the unit, I anticipate us working on outreach to reestablish or nurture these relationships. Next slide. This is ER visits, and I think you're starting to see the same pattern we're seeing. We're starting to return to ER visits. A normal year, a normal census for us would have been probably in the 700 a month range. We're getting up towards that, but we're not quite there yet. When we get Janet Lynn's on the phone, and maybe we can have her talk a little bit when we get further. But it could be that what we lacked was primarily the lower acuity visits. That the admission rates may not have changed that much. The number of admissions may not have changed so much from the emergency room as one would have thought with the drop in visits. Next slide. Okay, this looks at the financial position. This is, by the way, this is my slide. So I want to just say that Christine and the team didn't prepare this, but I wanted to have some kind of just general picture. And if you look from left to right, from fiscal year 15 to this year, and then what might be called a target for next year, we kept a budget deficit between, it's roughly in the 1 to 2 million range for 4 years. What really changed from fiscal year 18 to 19? There were some deferred costs from 18 to 19, but the biggest thing is we really went from a very thin staffing model and recruited in really premier clinical leaders in our intensive care units and staffing, as well as several other programs to really flesh out the clinical program. And really what we've been working on since is actually catching up the revenues and managing the expenses to sort of incorporate and manage that really superb staffing model, which has had a lot of good results, but has had some challenges in terms of just of deficit management. So, the deficit is coming down. Again, a lot of hard work. That's a projection as of April for 3.6 million. We'd like to get below 3 million next year, if not significantly below that. That's dependent on both the work that we'll be doing together, as well as work we're doing with the College of Medicine and the hospital in terms of how they're able to support the model further. Next slide. So the adaptation plan. So, what are we doing to kind of deal with some of these major issues? And then I'm going to talk about how this kind of cascades down to individual faculty life. So, in terms of the patient volume, inpatient, we're incrementally rebuilding capacity within the 5 West space. We're identifying overflow that could occur either internally, externally, with partners, if need be, to manage increasing clinical volume as that may occur. And then we're looking at outreach and marketing as we kind of build out the capacity to really meet additional, or there maybe you may say the pre-COVID community need. With the budget, we're going to leverage partnerships to strengthen the clinical model without increased costs. We'll talk about how that might occur. One of the realities is that the emerging partnership or affiliation document with Cook County is that they have services that we need. We have services they need. They're actually remarkably complementary, and that we can help each other maintain a full service pediatric program that's a publicly accessible model in Chicago, which I think is very important. And that potentially together in the future, we could even work together on co-marketing or collaboration on proposing value-based models, for example, to the Medicaid managed care sector. And then we're able to do that more effectively when we can state fully that we have a fairly comprehensive model. We do recognize we have surgical gaps, and we do think that the partnerships will help us eventually fill some of those surgical gaps. And the budget, costs must be maintained nearly flat from fiscal year 21-22 as we kind of go through this transitional period. And then partnerships, as I said, Cook County Shriners, looking at sharing inpatient coverage to reduce costs. We have complementary programs. One of the areas we did not score on for U.S. News was orthopedics, but we have a fantastic top-tier orthopedic partner, and that relationship is going to grow across time. Cook County Health is anticipating having a child abuse and neglect physician. We currently don't have one. That's something we've needed for a number of years, since Dr. Vancanini left. We can provide supports for their programs. They can provide support for our programs. And I think eventually we hope to collaborate them on outcomes and costs in partnership with, other governmental agencies in Illinois. And then we have an anticipated expansion of the ambulatory settings. We have this $22 million allocation from a combination of state legislature and UI Health. And then, we're looking at the possibility of clinics with UI Health. We put in a pitch in for the, I think it was 45th and Pulaski, and then we're also looking at in discussions with Shriners. I believe they will evolve. One of our really hopes is that we can move some of the subspecialty care closer to where families are, and then this can be a point of difference with some of the competitors in Chicago, and it could also optimize care by improving access. Next slide. So, we have a strategic plan. It actually ran through fiscal year 21, and you're all familiar with this. Really, we've kept pretty close. That plan was really built around a lot of the trend lines that we've described, and I think has been helpful to provide a framework for adaptation. One of the biggest gaps in last year when we analyzed it was we had not really evolved a partnership beyond Shriners. So the movement of the Cook County partnership to closer to fruition, and I believe will come to fruition in the next couple of months, was a major piece of the strategic plan that will be able to move forward into the future. Next slide. This is the sort of model that we've been working with, and I think one of the early, if you remember, partnerships is one of the elements of the columns of the strategic plan. Is because we realize that as a relatively small program, we need partners we need financial partners, we need clinical care partners, we even need research partners, we need educational partners to fulfill a pretty sophisticated and expansive mission. And so a lot of the work of the last 6 years has been building out robust, functional relationships with multiple partners, from the College of Dentistry to helping them get through the pandemic, to the Cancer Center, to building a closer relationship with them, which has really advanced the leadership of Dr. Schmidt, which has important support elements going into the future. That's just to name a few. But I think weaving that into a fully functional clinical and educational model is really where we are right now around many of these partnerships. Some of them are relatively more or less important in the clinical and educational program, but really drilling into that to make this a fully adapted, what we call a distributed care model within this Chicago marketplace. You go to the next slide. So this is kind of a re-rendering of that, and I know it's a little bit of some of the same information, but a slightly different way. And what I want to emphasize here is we're really looking at integration and optimal use of human and physical resources across these relationships to deliver the mission that we have in a very cost and outcome conscious environment. And under affiliations and outreach, really what we're looking at is, if you look at those key partners that we have now, those are going to become more and more important in fulfilling that mission. We can go to the next slide. I think there's the graph, the element of this graphic. Yes. So, what you this is coming, as we kind of look at this model to understand how we're going to function, and optimize care. So you might say this is a counterpoint to the traditional model of a very large, freestanding children's hospital model, which certainly has its place, but it's also been tremendously challenged by the pandemic and will be probably challenged going into the future. This is looking at the resources that we have, particularly in the public sector, and weaving those assets together to deliver on the model in a cost savvy way, but producing high quality outcomes, as is evidenced in the U.S. News and World Report rating system. Next slide. Here's another way of looking at it. We have an inpatient platform that's absolutely critical. It's the apex of acuity in our health system. On the far right, we have an outpatient system, which is really the backbone of the entire health system, which we're looking at new clinics. And I would also add, the emergency room is maybe sort of an intermediate space between the in and the outpatient, but it's a critical backbone element. We have a population health program, which tries to unify those, that I think will play an increasing role in the inter-interval care. We want these things to work together to lower cost, show value, express the triple aim, improve outcomes, do care coordination. And I would call that kind of a manifestation of a distributed care model using the physical assets that we have within the partnerships that we have currently or that are emerging. Next slide. This is another way of seeing it in kind of a business format that, we have patient, this is more of a primary care model, but we have kind of a patient-centered mental home. We have pay for performance contract, we have managed care contracts, we have an integrated health home. These are things that either we have or are working on or in a managed care way to kind of look at different aspects of the finances of the care delivery model so that makes sure that we are really in tune with the managed care environment and delivering what they want. Next slide. So we're getting to the end, and I realize I want to respect everyone's desire to have, this is a very long slide. And this looks at kind of like, what does that actually mean when we start talking about the budget, the transitional period, the restructuring that we think is going to be happening over the next 12 to 18 months. So I want to just go through this, and then I'm going to just suggest we go right into discussion, because I think this is a good place to end, because I think this is where we'll get into a lot of questions and discussion. So under, patient volume inpatient, we're going to have to use off-site rotations to supplement resident education, maybe even more than the original plan. And we're going to have to use the partnerships we have in probably new ways to strengthen the inpatient experience. We may need to follow our patients to other locations if we have to overflow to those other locations. We're going to have to incrementally build capacity within the current UI health framework. And we're going to have to just restart outreach to emergency rooms and other programs to sort of rebuild some of the business reputation that may have been lost during some of the closures. In the budget, we anticipate that a 10% incentive-based model will continue into the next year. That is not a new 10% beyond what was, you might say, at risk over the last year, but a continuation with a new set of incentives to be discussed and developed in partnership with the department, conversation in partnership with the College of Medicine. So again, I'm going to repeat that, not a new 10%, it's 10% is already there. We are, however, anticipating giving the 2% raise that was discussed by the university right now, if at all possible. We'll be sharing staff with other partners rather than hiring. If there's a capacity in a partner to provide us faculty, and we'll do this in a totally compliant manner in terms of changing value, we want to use that. We're going to continue to have downward pressure on professional travel and conference support. We'll provide specifics on that. We have to reduce food costs even more, hopefully minimize that. We've already gone through a tremendous period of administrative cost reduction. The administrative staff has been dramatically downsized over the last 2 years. That will probably stay where it is with maybe some minor modifications. The main area we increased was HR 7, which I think everybody agreed was one of the most challenged areas in our administrative infrastructure. Check was restructured into independent funding. Some specialists have been asked to be preceptors in general pediatrics clinic if they didn't have enough clinical activity or other covered activity. Moonlighting costs either have to be flat or decrease. And there have been maybe selective staffing reductions. That is actually looking at where we don't have a need for that service and giving the person as much advance warning as possible and facilitating their transition. Partnerships, we're in the final contracting process for the CCH affiliation. I want to say that the university and the health system has worked with us hand in hand, almost continuously for 2 months to get to what looks like a final wording, and those documents will start circulating for final approval shortly. We're still calculating the fair market value, but I expect that we hope, signed documents within 4 weeks. Shriners is very enthusiastic about growing its relationship with us, both in the inpatient and the outpatient. Anticipated expansion into in the ambulatory settings. We're going to need to reassess clinical time allocation as we hopefully increase the number of people in call schedules. When we match that onto the existent CFTE policy, that will reduce the amount of time clinicians have to spend on call, and will allow them to spend more time in the outpatient space, which will allow us to generate more revenue per faculty member. And I think hopefully that will be reflected in some of these incentive models that we will develop together. And then we'll be starting some initial planning for the new facility, and then also for offset locations. I'm going to stop there. I was off by 9 minutes and just throw it open for questions. That was a lot. I just want to make sure that the basic information got out. We're recording this. We'll make it available to faculty who could not attend today.
Hi, Ben. This is Deanne. And I just wanted to mention that I think, it's been a really rough year and a half, and there have been some pluses, as you mentioned, that have come out of it. But I just wanted to mention, and especially with Janet here today, that I think one of the pluses that has come out of this is I think there has been, at least in my section, and neonatology is usually off on its own planet, a renewed sense of being part of a greater whole, and that our colleagues in not just pediatrics, but medicine and across the board, that we really have been in this all together. And we have new exciting partnerships that have come as far as, doing clinical research work with Department of Medicine on vaccine trials in pregnant women and looking at the impact on the infant. So I just wanted to mention, and again with Janet's sessions in the morning, they were such an anchor in a time of troubled waters. It really was helpful, and I do think that this will help us become stronger partners within the institution as pediatricians. And I hope that as we're going through our continued challenges, that people will understand our needs at the same time. So I think there have been some good things too.
And Deanne, I just want to echo the sentiments. This is Joanne. And Ben, you and I have spoken a little bit about this, but I also want to give credit to Peter Varga, who's on the call. Dr. Shukla is retired, but isn't part of it. But as Deanne alludes to, there's been some beautiful professional relationships that have developed from the pandemic, including a global health stamp that we have now in Nepal. And that came to fruition through the policy pieces that Deanne, Artie, myself, and others published and presented internationally. Through that, Deanne and I were contacted by folks in Nepal who are in the midst, as we know, of a public health crisis. And our group has really stepped up to the plate and work with the scientists and physicians in Nepal, mainly the physicians, as we help them with policy. Peter can attest to, we have a Nepal call tonight. We meet 10 o'clock every week. Dr. Shukla, myself, we have an MD PhD student and a collection of really committed public health folks. So while this is not how I thought my year would be evolving, nor did I think my evenings would be like this, it is a beautiful opportunity that we've had to provide a service internationally, to build the global health work that Peter is spearheading as he takes over Dr. Shukla's work, and is, just as I call it, one of the pandemic positives.
Thank you, Joanne. Appreciate it.
Ben, this is Claudia. I missed the beginning of the meeting, so I apologize. I was coming from another meeting. I have a few questions for you, just based on the restructuring. As we expand our outpatient clinic number, how are we planning on doing that, utilizing our current clinic space? Because it just seems like we already have so many providers and not enough rooms. That's my first question. And then the second question is, if we add on more clinics, but right now we don't have a long waiting list of people who are waiting to get in, how are we going to build up the volume so that we have an adequate number of patients to fill those clinics, and we don't just have physicians in the clinical setting without full clinics? Because then the payments don't really go up. It's just that we're there doing clinics, but people aren't coming. So is there a duplicate process to also kind of increase our, I guess, outreach to those outside pediatricians to increase the volume?
No, I think it's actually a really, several good points. And just to deconstruct them, I think, the current footprint, is limited in terms of the clinic space available. Then maybe Friday afternoon may be one of the few spaces. And then, some of you are working in the evenings. We really appreciate that. One of the challenges in this setting is that we often have a lot of conversations that are fairly consequential, but we can't always share everything about it. But I would just say that we are involved in at least one very consequential offsite clinic discussion where another organization actually wants us to come in and wants to host us there. And so where that discussion is right now is they're doing a marketing analysis to understand, what would be the demand for different subspecialties, what do they need there, and could that be a viable offsite clinic? That would be 7 or 8 miles from here, but also relatively convenient to where most of our faculty live. So that's an example where we're trying to marry kind of, optimal, positioning for our families, our patients, but also being realistic. I think the question you're asking, have we kind of, peaked out what the number of patients we can move through the current clinic, either because of the staffing or just even the location? And I think we're working on a presumption that the only way probably to significantly increase patient volume, unless it's a specialty that has a big waiting list, is to reposition individual faculty, at least some of the time, to a clinic that's closer to where some of the demand actually is. But we're going to do that after careful market analysis. We're not just going to go willy-nilly into a site. In this case, the partner actually has endogenous demand based on their own surgical programs. They have a lot of need for consultations in some specialties, so kind of provide a base demand. There's an interest. I mean, I think that there's an interesting phenomenon in Chicago. There's a sense from some empirical work that in the inner city, many individuals never get to see a subspecialty they need to see, that there's unmet demand. It's been very hard for us to sort of, get that, jump over all those barriers. And I think that's where the outreach is going to absolutely be required. And that's going to be a partnership probably with the university system as well. I agree. I don't think that patients are going to magically appear. I agree.
Ben and Janet, as somebody who uses the inpatient unit instead of the NICU, and as co-chair with Claudia as faculty affairs, I just can't report a positive feeling regarding the last year and a half. I think that the people that use the inpatient space have deep morale issues right now. I think that the abrupt closure in March of 2020, and then the vague promises of when we would get a bed and really forcing a bed because the patient needed it, and then clawing back bed by bed by bed has really worn people down. The faculty have asked for the hospital leadership to come and meet with us, but they have not. Janet, I appreciate you on the call today, but that's not the same thing. Tomorrow, Terry Vandenhoek and Mike Zen made time to see the house staff, but have not made time to see the faculty. So while the presentation that you make is really impressive and educational and from a 30,000 foot view, it makes sense. But for those of us on the ground that are trying every day to get a bed for our patients so they don't have a carboplatin desensitization protocol in the infusion room where there's no monitor, but we're trying to make room for another patient that's equally deserving of another bed. And it's exhausting. It's truly exhausting. And to say that we're going to have 24 beds next week, when really we're going to have 13. And we're really not going to have many more than 13 because of cohorting issues, staffing issues. 13 beds is not enough. And I was on a call with leadership across many departments, and literally somebody said, who's in a leadership position, when I raised something about peds, they go, "Oh, I don't even think about pediatrics," literally out loud. And it is demoralizing. So my plea to you, my plea to Janet is that the faculty want to meet with the hospital leadership, with the dean, we want transparency. I think what you presented is beautiful. I see what you're saying, but we have patients right now that we promise access to, that we promise to reduce health disparities. And when we send them away, or we can't bring them in, or we can't welcome them, we're not meeting our mission. We're not meeting our mission for care. We're not meeting it for education. And therefore, we're not going to meet it for research.
Just to dovetail, Munir's, just to be clear, to be fair to the dean and Mike, so they're planning to meet with the leadership group of the department. The only reason they haven't met really thus far is that we were trying to get through some of the budgetary partnership issues and also some of the immediate bed issues so that there would be more substance to discuss. So Mary Lou's comments are well placed, but there is a plan to have them come. And I'm sure they'll meet with the faculty as a whole. They may meet with the leadership first. And I think that might give them some agenda issues. And then they will meet with the faculty as well. So I think Mary Lou's comments are well put, but there is a plan to do that. It's been, sequencing that relationship to all the other steps.
Ben, can I chime in? And I really appreciate, I think, your perspective, Mary Lou. And I think we all feel it. I think Ben shared the contraction of pediatric volume. And I think that was felt across the board. I mean, I can say specifically for our emergency department, I think we faced a 40% contraction of our volume as well. And, a lot of different pressures in regards to where do we see patients, how do we actually see patients, et cetera. And so I think coming from, having been invited more to kind of at least represent not exclusively one department, but maybe more of a hospital perspective, I think key message is every single department is feeling the same contraction. So it's not singling out any one department in regard to that. And even having gone through a lot of the COVID, there were no easy decisions in regard to how to balance the need, the capacity, and the demand. And I think a lot of this is not going to be a positive for any one entity, but I think also some of the decisions are intended to be made such that we have the ability to have these types of discussions of opportunities within pediatrics. It's not sufficient by any means, and I think that's the ongoing effort that all of us have, and I think Ben has been doing a really, yeoman's job in regards to trying to find those solutions and address some of those issues. And it also, I think the other pause that we have to do is there's a change in focus in the types of conditions. The conditions in which you care for have not disappeared, but at the same time, we're also balancing some of the, the different focus in regards to thinking about, are there new conditions or complexities related to that? There's a lot of mental health and behavioral health issues that I think have been overlaid now on some of the existing chronic conditions that people see. And is that as a result of COVID? Is it a result of postponed care? Is it just de novo? I think those are all things that we're trying to face and figure out how we can actually respond to in as nimble of a way as possible.
Thank you, Janet. And thank you, Mary Lou.
Hi, Ben. This is Ed. Janet, thank you very much for your comments and your attendance here to giving us some background. I'd like to echo Mary Lou's sentiments, but I'd also like to plead with you and administration and to really be transparent and forthright with our department. As Mary Lou had said, that there are many times where for the past 18 months, for the past 15 months, we've been given pretty much the same answers. And I think realistically, if all of us as adults here in this meeting should be able to handle truthful answers, forthright answers from administration. I think the fact that you said that everybody in the hospital is undergoing contraction, that's not true. You can't say that's true for the fact that adult medicine is taking over 5 Southwest for step down ICU. And the fact of the matter is this isn't personal. I don't think it's nothing against pediatrics, but it's a business decision, and a business decision in which the hospital is trying to recover significant financial losses from COVID in the best way possible. So therefore, if it's a business decision, we can expect that as true, and we would accept that. But the fact of the matter is that we've been given so many different answers and positive spins on how we as a service are being contracted, and that how we're held, but yet we're held in high standards and high regard by the institution. The optics just aren't there for us. So to echo Mary Lou's sentiment and speaking for the inpatient services, the faculty, the residents, there is a significant amount of moral distress. And the fact of the matter is, to hear leadership say that we'll meet with you on our terms, as Ben pointed out, maybe possibly at the end of August or beginning of September, quite frankly, I think shows a lot of disrespect for the rest of the faculty within our department.
Thanks, Ed. Appreciate it. I think we're going to speak. Go ahead, Dean.
No, I don't want to interrupt you, but after you're done, I have a comment on something else.
Yeah, I think just acknowledge. I think Ed's got some well-placed comments that there's been a lot of communication. Mary Lou described it sort of clawing back bed by bed, and then probably ambiguity about different places where we're with a positive spin on top of it. I will certainly acknowledge as someone who puts an optimistic spin on just about every situation, and so that I can see how that could also have been frustrating. But I think what we're aiming for is, I think with Janet's appointment to work closely with us to be able to kind of cut through some of the miscommunication and get more clarity, and also really optimize the planning. Anyway, I'll stop there.
Okay, thanks, Ben. I wanted to come back to the morale issue on a different aspect of academic life in pediatrics and wearing my academics hat, and that is the reduced professional travel and conference support. Are there any specifics on that? I just want to point out that, part of the reason that people accept sacrifice, accept lower pay, etc., to work in an academic institution is because of the rewards that those other professional interactions and scholarly work and accomplishments come by, going to meetings, having a greater peer network, who have shared values. And I just want to emphasize that reducing professional travel and conference support may have greater implications than simply a budget checkbox, because I do believe that it is intimately involved in morale. And this past year, it worked okay because so many meetings converted to virtual and there was no travel. But going forward, I would hope that this would be recognized that this is important, and that it does play into people's professional self-value and how they feel about the institution and the support. Along those lines, I just want to mention that at a previous institution that I worked, which chronically had fiscal challenges, they set up a pre-tax business account that we were able to voluntarily supplement our professional travel and conference support by designating, in the same way we do for FSA accounts, a certain amount of money, so that even those costs that we were picking up personally, there was some savings because we were using pre-tax dollars. So anyway, just wanted to emphasize that particular aspect of the summary.
Deanne, I think that I just was going to say, because Ben, you and I have talked about this, part of how, I'm putting my scientist hat on, part of how I've dealt with some of the budgetary issues with being a scientist and NIH money being tighter, unless perhaps you are doing COVID research, which I'm blessed to be participating in, is to get private funding. And as you and I spoke about, some of my pitches for private funding come from the country music industry through dear colleagues I've worked with over the years. So for me, not only am I collaborating with another city like Nashville because I work at the bench there, I have samples that just arrived from Nashville to Chicago, but that trip was critical on a research level for establishing philanthropic relationships that are important for an institution that's in the situation we're in. So I love that idea, DM, because I can't keep my research program going without funding. And part of how I'm moving forward with my research program as we have this really exciting NIH COVID trial that Deanne alluded to, because I'm not all about pandemic positives. I have a research program to keep active. And part of how I'm doing that is going the philanthropy route. And again, that is very much travel based and should not be part of my personal expenses, but needs to happen.
Thank you, Joanne. I wanted to say acknowledge there are several comments in the chat. If folks are able to stay on, I'm going to just try to go through them, and we'll see if I'm going to just. I think the first comment, and I won't give names because I don't know if I'm not sure how people feel. Okay, or Jordan, you've got them up there. Okay, yeah, that's fine. Okay, so I think that one of the issues brought up is neurosurgery. It is a huge problem, both in terms of basic neurosurgical services which we do not have, and then some of the subspecialty ones. We recognize that, and as I said before, and I know this gets into this frustration of like tomorrow. We were very close before the pandemic with a model we thought that the institution could probably support, neurosurgery could support, and unfortunately we had the pandemic. We're going to revisit those either in a partnership framework or maybe even revisit that original model. It will help us in the partnerships if we can aggregate up volume so that, let's say, a neurosurgeon, which is an extremely expensive asset, even if we're sharing, let's say, a third or a half of that person, that cost can be shared around, because it may not be cost effective from a pro fee standpoint alone, but it's essential for our system. There's a comment from Dr. Bernstein about the Cook County. I want to say that no partnership we might develop is a panacea or a global solution to everything. There are some specialties where it will be very helpful, some where it won't help at all, some where they have a history of having that specialty, they plan to acquire that. So I'm not trying to over present. Once we as we work through the framework, we've tried as much as possible to go specialty by specialty to see what is even possible. Once we actually, move ahead with the agreement, then it's going to be working specialty by specialty to see how we can create models together. So no one's trying to say that, we're going to, build this relationship with Stroger and suddenly everything's great. No, it's another, well, more than incremental, but important step to aggregating volume. With Cook County and us together, we probably care for over 100,000 children. That gets us into probably caring for probably 1 in 5 or maybe even 1 in 3 children in Medicaid in Chicago. We become a significant potential partner for managed Medicaid organizations. And so there's a lot of attributes that will emerge both from individual relationships by specialty that may or may not be helpful, or through working together, but it won't be a panacea. I think this is a comment from Lewis. Is there more hope for support for the university in recognition of pediatrics as a key role in educational mission and community mission? I think there's absolutely a recognition of that. I'm maybe a good question would be, what that would look like, and maybe we're going to run out of time, because I think understanding, where our faculty see the gaps are, kind of like how Mary Lou and Ed were kind of describing where the gaps are seen, and would be helpful. I don't know if Lewis or anyone wants to sort of, I mean, I know I could reel off what I would think are usual suspects, but if anyone wants to amplify that.
This is Lewis, just wondering whether there's more financial support from the university for our educational mission, so that we're not just a service line trying to also support education.
So just briefly, the university does give us about 1.1 million every year for educational activity. That's a combination of state legislative support and tuition dollars. As we share with the College of Medicine, that does not support the entire educational medicine, particularly when you add the undergraduate plus the postgraduate. It absolutely runs at a deficit. The position of the college is that they don't fund postgraduate medical education. Probably the position of the hospital would be that they do give us money back in tech fees. It's a really complicated, so I don't want you to think that nothing's being done. We believe that our educational mission is undervalued in terms of what we produce as a core clerkship in terms of interactions with students and what we actually get. So I don't want you to think nothing is being done. I agree. I think that our faculty does a tremendous amount of teaching that isn't really captured. I think one of the things we're going to have to do is find a way to capture that time and have it presented back of how that can be supported. As you're right, otherwise people feel like they're reduced to being a service line, which is not anyone's intent at all.
So this is Deanne again. I would recommend that exploring the model they're using up in Wisconsin at UW that was developed by Phil Farrell when he was dean. And they have a system called Mama Dollars, where they keep track of each individual faculty member's contributions to undergraduate medical education. And then the department receives back a certain amount of dollars that's proportional to that contribution, of which the individual faculty member then get a supplement to their salary that specifically reflects that contribution. It's done a lot to make it more equitable between departments, and it's made the competition actually from faculty to be involved in undergrad education. It's something that's very desirable because they see a direct benefit from that. So I would recommend looking at their model, because it was one of the things I felt worked exceptionally well there. And if we don't feel that we're getting our proportionate share of support, that model evens the playing field.
Well, I think that's what you're proposing, Dean, is some kind of a systematic, attribution of effort to tuition dollars. And I think that a lot of the chairpersons actually feel that. And I think there's going to be some change across time as I think a lot of work is being done to kind of organize and rationalize a lot of the, the resource allocations. And I think our faculty are just leaders in education. I think that's a definite possibility that, that we may have a say in that. There was one question about, is the bed space adequate for the population? So I just did a quick calculation and recognizing this is inadequate, but I kind of calculated based on probably an ongoing patient population of about 60,000. 75,000 is the number of people that have touched us in the last 3 years. But of course, people drift in and out. Sometimes they just have one procedure. So I said, 45 to 50,000. That converts into an ADC probably in the 16 range. Okay, so the problem, of course, is that could go from 25 to 5. But I want to say that if FSA Cook County and we are in on a consort trying to serve the urban youth child population, that in aggregate we probably have quite a bit of bed space. But obviously there are higher acuity patients that were completely the higher acuity patients need to be in a university environment. There's some lower acuity patients that maybe could be in a more community hospital environment. So I think that's what we have to think about. What are the assets we have in any partnership that we might form, and how can they be used to serve our mission? And interestingly enough, before COVID, that, kind of when we aggregated all the census, we came up with about 13, 14, 15 as the aggregate average census, and the population estimate is 16. So, 13 rooms, as Mary Lou says, is probably not enough to do all that, but it's at least getting a little closer. Okay, I think there's a comment.
Just one more
yeah.
comment you said regarding the number of beds and ADC. I hope that the upper administration realizes, from any children's hospital standpoint, a very high sustained ADC model doesn't rely on general pediatric admissions or seasonal admissions. It relies on specialty and surgical services that have continued support for their patients and continued growth of their services. Over the past number of years, we've lost neurosurgical, we've lost cardiac surgery. Obviously, orthopedic surgery is still significantly up in the air. I know Dr. Margetko's doing his best of the job possible with his spinal fusion patients that he admits here and there. But we've had a significant hit to some surgical specialties and medical specialties over the past number of years that have not been either re-energized or supported to get back to an appropriate growth pattern.
I think it's just, recognize that the recognition of a loss of acuity from surgical admissions that's been a major problem for us, and that each of the losses has had a really substantial impact on the census itself. And CT surgery was complicated because of the movement broadly held to try to aggregate those in centers that had more than 100 130 procedures a year, which we got caught up in. Originally there were more than that here in the 1990s, but then it was down to about 30. I think that we'll probably have more luck with some of the other surgical services regrowing than that particular one, but the point's well made. There's a comment here, I think, from Karen about the salary and the budget deficit. Any expense change we have is rolled into it. When we do manage things like an incentive model, we don't budget that no money will come back. We budget that an estimated amount will come back. On average, across the College of Medicine, about 60 to 65% of the incentive has been returned. In the department, I don't know where we'll land as a department for the whole year, but I'm guessing it'll probably be in the, maybe the 40 to 45% range once we have the fourth quarter recorded. So the goal would be, as we create the incentive model, is that probably as revenues rise to cover some of the expenses, then we'll be able to return, then there'll be an opportunity to recover the salary that's been withheld. So that the departments or the universities and center will be aligned with the faculty member. Added a question about diversity and inclusion. I think, we are, leaders in working with families and communities on multiple levels of from high acuity to, relatively community-based, pediatrics and engagement. And I believe the university does recognize that and looks to us as leaders in that area. I want to thank Dr. Lynn for being here with us. I think that was just tremendously helpful for her to be here, and also for y'all asking so many outstanding questions, making outstanding comments. I think it's really helpful. I want to make sure we've everyone who's wanted to ask something has been able to ask. Okay, how many PCRs operate in the black? I think that is very few. The models I've seen where they come closest to being black, let's say like a relatively small deficit or operate in the black with all sources in, are ones in which they're, maybe being paid back. On our view, they don't manage their clinic expenses, right? So that's a big chunk. And the university basically has an RVU reimbursement model, and often in a very lucrative environment where they're getting back like $100 per RVU. Those pediatric departments, which also have relatively busier inpatient ones, may come close to breaking even. We currently receive from the College of Medicine about $1.1 million in tuition reimbursement and legislative allocation. We also, and I'm going to just give an estimate, receive about $700,000 in just specific targeted support that relates to, growing and developing the programs itself. The hospital, as of last year, provided us about $4.2 million in a variety of support models. Over the last maybe 3 years, the support of the hospitals actually increased by over $1 million a year. They are working in partnership with us now around the PICU to support the PICU in the Leapfrog program, and they're also working with us as a partner in the entire program. We are essentially working together. We're doing our part, and the institution is, committed to doing its part to have an outstanding pediatric program.
Ben, it's Mary Lou. I really appreciate this session. And Janet, I don't know if you're still on, but I truly cannot emphasize enough that faculty, in order to have the educational programs and the training programs, you have to have an engaged faculty. You have to have a faculty that believes in their future here, their family's future here. And so I strongly, strongly, strongly encourage you to set a date, invite the leaders, have a clear set plan for the inpatient unit. That this, I'm just trying to bring the message home from the faculty. It's this, they really need it. I can't say it strongly enough.
I think it's a great idea, Marilyn. I think that's very wise to say. I think it's really helpful just to get everyone actually in direct conversation with each other. I agree, it's extremely valuable.
I want to say that, Ben, because I just want to say, as much as I've presented some of the efforts that myself and others have been doing within neonatology and pediatrics, my family does not see me that much. And wearing my scientist hat, while the pandemic is not the clinical detriments are diminished. We're getting vaccines out. We're seeing improvements in our numbers. My work as a scientist in the pandemic and the gut microbiome is just starting. And while that stuff can be put on hold, it's not patient care, it's not critical babies. From a public health standpoint, from a commitment to my vocation as a scientist, it's critical. And I'd like to see it happen. I'd like to see this vaccine trial we're doing go on to success and potentially be something that we have our own funding for in the Department of Pediatrics. So it's very hard to do that without the support and time with my family and with loved ones that brought me to this point. So I agree with you. I just want to echo those sentiments that this pandemic is not over for us. And I find it's even harder as I move forward in this second year, now as more of a scientist and an international policy person than it was when I started the pandemic.
Well, you know, I think what Joanne's speaking to is, you know, the complicated roles that many faculty have, that they're facing, you know, literally physically and metaphorically facing, you know, learners, policy, you know, clinical work. You know, it's a really complicated job to be a faculty member, and you got, you know, much more complicated during COVID, and then salaries have been cut, you know, effectively, for want of a better term, you know, the result of not getting all the money back. People feel insecure about their family's relationship with the institution. I agree, and I think Mary Lou's right that having that direct conversation will help, I think, rectify some of that. I want to make sure that I want to just come back to the questions, but I would just say that I think there is no adult alive today, or even older child, that will be the same after the pandemic than they were before. You know, the amount of cross-cutting, complicated demands on people are enormous. Every living person will be thinking and talking about this the rest of their lives. In fact, they'll be telling it to their grandchildren. Our children will. And I think, as Joanne's alluded to, you know, we're sort of still in it. I mean, even this entire conversation is to some extent partially related to the pandemic. I think there's a comment about, you know, around, you know, the resource allocation around, you know, you might say non-direct clinical service activities, conferences, teaching. I agree with you that when we try to rationalize, so to speak, you know, and be really specific about clinical services and put all these incentives around them, but we don't deal with the non-clinical activity, it by default tends to kind of like suborn those activities or make them either appear or seem less important. And that is also something I've shared with the department heads in a group that's it's a really, really important.
Can I make a quick comment? This is Christiana. So I'm, you know, obviously a new face in town, just a year in, and looking at all the sort of the big picture of what the presentation has held so far, there seems to be a contrasting picture where there's a lot of achievements that were recognized, you know, the U.S. News, based on work that everyone has done over the last few years, using a larger capacity, using a lot of you know, hardworking and smart minds. Then it sounds like there was an investment in 2018, kind of bringing in even more faculty here. And then all of a sudden, there seems to be a shift in the short term, sort of what is the budget now? How can we, you know, focus on getting more folks here, but less folks there? Whereas the vision, it seems like if we want to kind of keep this, the U.S. News ranking and everything else, it seems like there has to be some investment that looks at the long term, at the growth over time, because I mean, it is a limited market, and as these sort of cuts are being made here and there, the morale goes down. Eventually, long term, we're going to lose that share because people are going to leave. You know, beds are going to get smaller and smaller. We're going to lose our presence. And so it seems contrasting to me that there was this vision of a long-term investment in the pediatrics program, and all of a sudden it has sort of just shifted and took a corner to this kind of short-term view. So that, again, from kind of a looking at this relatively with a new vision, the contrast seems stark. Yes.
Yeah, just to respond, so it's a good comment, and I think it's just to say that the broader vision that we've had for the program to evolve, you know, in the urban space as a sort of a different structured program, I say, than Lori or Comer, you know, has been there since 2016, and we really have persisted in that, and I think through the endeavor of the faculty has succeeded in that. I don't think there's only shift to short term is the reality of, you know, one part of this is post-COVID, is that there have been, substantial changes in patient volume that have dropped our clinical revenue, that have made it hard to fully take advantage of some of the, you may say some of the hiring and investments that have been made. The goal of this is actually for the program to grow in, and when I say restructure, I don't mean restructure towards like tomorrow. I mean for the next 10 or 15 years. When we're looking at trying to put together partnerships or facilities or an aggregated faculty, we're looking at that 5 to 10 year horizon. So when I'm speaking about, getting through this budget year, I don't want that as, that's a tactic to probably get to a point where our clinical volumes start to recover to where they were, and other short-term factors that I think we're going to weather through, but then also to adjust to perhaps a slightly different structure of care. But I don't want anyone to left with the impression that we're just trying to manage the next 6 months. And no, it's all part of a larger plan, and that we've in aggregate labored on together.
Ben, I'm concerned about the fellowships because in your plan, you spoke about sending the residents out to outside inpatient, to do inpatient rotations at outside hospitals. But in our contracting our inpatient unit, that decreases the teaching or the availability of patients for the fellows. So how do we handle that from the fellowships program standpoint?
Well, I think first of all, we don't know, how long it will take for the clinical volumes to recover, given that there are many factors influencing that right now. So I don't think the desire is to shrink the inpatient program, it's to actually hopefully that it recovers. I agree. I think that unless there's an overflow capacity, it would be hard for us to hit the ADC that we had before without either overflow in our hospital or at some other location. But I would say, let's just say if we had a complete recovery of our volume and it was mostly in our own hospital, let's say that we do succeed in setting up some sort of offsite service at Shriners or maybe Strozier, then our fellows could travel with the patients there. So I think a core question is, can we recover that volume? How much of it can be managed within the current space? And then how much of it might end up at a partner institution that we would still be working with? Those are the things we'll be working on over the next 18 months. I think, and I think with the fellowships, that was the question is that there's your individual basis, whether, we evolve other partners to work with us, if the Rush collaboration does or does not continue.
Ben, I know we're probably getting close on time, but I guess I wanted to make sure that I thanked you for the leadership that you're providing during the pandemic. I often am a positive person, but I came up with pandemic positives as a mom of 3 children during a pandemic, because at the heart of the matter, we're all pediatricians, right? And I knew this was going to be the hardest thing possible for my children, all of different ages, all going through different experiences, all going to take this with them throughout their entire lives, just like you said, Ben. And I knew that in order to step up as a mom, I needed to help them see the beauty during a really, really challenging time in our country on so many levels. So I can tell you that that is what I see you're trying to do for us as a group. And I imagine that is not easy. I know I struggle with it every day. I tell my kids at the dinner table, let's just come up with one thing. So thank you. Thank you for what you're doing. And I know we all pray for this to get better and not worse.
Thank you, Joanne. I really, really appreciate it. And as I kind of acknowledged in some of Ed's comments, I think that sometimes I do come off as maybe overly optimistic. It's part, as Joanne is stating, part of it's just, to try to kind of provide a kind of an overall directiveness of how we're going. And, but I'm actually very, very hopeful. I'm hopeful for our society. I think a better society is actually emerging, at least in my lifespan. I'm more optimistic for our society than I've been probably any point in my lifespan. And I feel really good about the way our society is evolving and taking on new perspectives. And actually, I think that we've actually never had more engagement from the college and the hospital than we have now through everybody's efforts, you know, even if it's some of it's contentious and conflict ridden, you know. So I think good days are ahead, and if we keep you know, working together and trying to be as honest as we can with each other, and I can't say that I'm going to drop my optimistic blush, but I'll try to make sure we get the direct contact that some of you, like Mary Lou's asking for, more of that, and then also, you know, make sure that the statements of reality are, you know, just feel like concrete enough that they're not don't lend to misunderstanding. Well, this is an unbelievable meeting. I think there were 58 people here originally, which is a tremendous dedication, but 32 still on, an hour and a half in. So thank you all. We did record the meeting so our colleagues can see it, and then you know, this dialogue will be continued, and I will work on the meeting setups to follow. Thank you all. Thanks. Thank you.